Uh, Good afternoon, everybody. First of all, I would like to thank Dr. Abdulazim for organizing such well-organized and informative conference webinar. And also thank all my colleagues who just joined us today. And special thanks for Dr. Ahmed for continuous support for the doctor. Today, I would like to talk about neutropenic sepsis because it is a quite important topic, and it is a medical emergency. And it's just like heart attack and stroke. And if it's not treated very well, it can lead to very serious consequences. Can we go to the next slide, please? And the next. So I will start by giving a case scenario for a 55-year-old lady. She is a known acute myeloid leukemia admitted to the hospital for elective cycle 2 chemotherapy. Otherwise, her background, she is quite fit and healthy without any chronic disease. And her fertility score 2, that means she is quite an active lady. On day 10 of her chemotherapy, she became pancytopenic. Her neutrophil count was 0.2, platelet 30, and HB 76. And because she is neutropenic, she moved to the side room. Before that, she is in the bay with a patient who just recently diagnosed with COVID-19 two days back. So she got a contact with the patient who is COVID positive. Can you go to the next slide? At the night, she got a mild cough and she spiked temperature at 38. And the doctor at night treated her as usual neutropenic sepsis according to the protocol by taking a blood culture, give IV fluids, antibiotics, and they also done all the septic screening, including a COVID swab. Next. Her observation at that time where the SAT is 91 on room air, respiratory rate 24, blood pressure 110 over 67, and the heart rate is 108, the temperature 88. On examination, according to documentation, the doctor found this bilateral fractures. And the ABG at that time was normal, and the chest X-ray showed a bilateral airspace shadowing. Could we have X-ray, please? So it's her X-ray at that time. So you can see there's some opacities and airspace shadowing. Can you go to the next slide? Yeah. In the following day, in the morning, she became more unwell, and she required more oxygen. She became more tachy, and respiratory rate 30, saturation 92 on 4 liters of oxygen. A heart rate 112, and blood pressure the same. Her blood test at that time, the neutrophil is going down 0.1, platelet 21, and HB 74. Because the patient on day 10 of chemotherapy, we expected the patient full blood count and the neutrophil is going down, because when the chemotherapy is going forward, the blood count and neutrophil is going to be more and more. So it's very difficult. This patient is going ahead for pancytopenia more and more. At that time, also her creatine and D dimer were high. But thankfully, the clotting and use and ease liver function tests were normal. And as ABG showed, type 1 respiratory failure. Can we next? On the same day, her oxygen demand increased to 50 liters, and the COVID swab came back as positive. So she got the COVID pneumonitis. CT showed a ground glass appearance, and a repeated ABG that was in type 1 respiratory failure. According to our hospital policy in such kind of patient, we usually shift them from the usual hematology or oncology ward or medical ward to respiratory ward for supporting by CPAP. And if the patient is for more escalation, they can move them to ITU or CDU. So the patient moved to respiratory ward for CPAP, and I think later on also she went to HDU. Can we go more? This is her CT. Okay, well, yeah. So neutropenic sepsis, as I said, it is quite very important topic. If it's not treated very well, can lead to a very serious consequences and complications. I will start by giving a definition about neutropenia. It is an absolute neutrophilic count less than 0.5. And the fever, it is a temperature more than or equal to 68. And also sepsis is a systemic response syndrome for infection, which can be manifested by a high temperature or hypothermia, temperature more than 38 or less than 36. And also it can be manifested by tachycardia, tachypnea, or hypotension. This is the sepsis. Septic shock is a severe hypotension despite adequate fluid resuscitation, and usually it requires an trop or vasopressor. In some patients also the neutrophil is not, there's no neutrophil to produce fever, and they can present with hypothermia. And any patient who present with rigor or hypotension and neutropenia should be treated with as neutropenic sepsis. So the message here is any neutropenic patient who came unwell, came to the hospital with high fever or hypothermia or rigor or generally unwell, we have to think about neutropenic sepsis and have to start the treatment as soon as possible. Can we go to the next slide, please? So neutropenic sepsis is considered as the primary cause of mortality in 36% of cancer patients, and also it considered a secondary cause of mortality in 68% of cancer patients, and in the most common cause of mortality and morbidity in cancer patients. Slide, please. The cause of neutropenic sepsis is either the failure to production of neutrophil from the bone marrow, or the destruction of neutrophil outside, outside of the bone marrow, and the other causes also for neutropenia. The category 1 is the production of neutrophil from the bone marrow affected, either by the disease in the bone marrow itself or by an external agent that suppresses the bone marrow. The disease itself, like leukemia, so leukemia itself can cause neutropenia, and also other hematology conditions like MDS or myelodysplastic syndrome. And most commonly, chemotherapy is the leading cause of neutropenia we've seen in our hospital, and also radiation to the body can cause neutropenia. A destruction outside the bone marrow, maybe by autoimmune disease like rheumatoid arthritis or lupus, and there's other medication can cause neutropenia other than chemotherapy, like there's some antibiotic, some antipsychotic, and also some antibiotic medication. And infection, commonly HIV and tuberculosis, also can lead to neutropenia. And next slide, please. So here, there's a genetic and acquired cause of neutropenia. In adult, as I said, mainly malignancy, infection, drug, and autoimmune. Next slide. So the presentation mainly with the fever. We've seen a lot of patients came to the hospital with a fever, and this is a classical presentation. But also the patient can came with hypotension, with hypothermia, tachycardia, and confusion, with feeling generally unwell, and the other sign and symptom of infection in the lung, like cough, shortness of breath, and according to the system involved, cellulitis, diarrhea, and dysuria if there's urinary sepsis. Next slide. So in history and examination, it is very important to inquire about a recent treatment with chemotherapy, most likely in the last 6 weeks, because at this time, the risk of neutropenia is very high, and we have to take a full drug history. And most of the patient will have a chemotherapy alert card with them to determine what kind of chemotherapy they're receiving, and also in the note we find the patient doctor or consultant. So if you are doubted of anything, you can contact the doctor number or the consultant to clarify this type of chemotherapy for you. And also we have to look for the infection symptom, like general, like rigor, feeling unwell. You have to also ask about cough, sputum, difficulty in breathing, in the urinary system. You have to ask about lion pain, dysuria, any discharge, and if there's any history of PICC line insertion, you have to look for a redness or sign of inflammation at the site of the PICC line, or there's any discharge. Next slide. We have to also ask about symptoms of sinusitis, nasal congestion, any runny nose, all of these symptoms of ENT problems. You have to inquire about diarrhea, tummy pain, and skin, for any skin rash, any redness, any soreness in the skin. All of these just to by system, because we need to take a very good history to find out exactly where the site of this infection. And in the CNS, also, we've seen a patient come in with symptoms like meningitis and photophobia, and very mild wound also can cause sepsis for this kind of patient, because this patient is quite immunocompromised, and any simple thing can cause sepsis for them. So we have to be very vigilant and take a proper history and proper examination to identify the source. Next, please. What investigation we need to do for neutropenic patient or patient coming with sepsis? Generally, we will do a couple of counts, looking for neutropenia, thrombocytopenia, anemia, and also a clotting screen. We know sepsis can derail the clotting, and also can cause acute kidney injury, and so we need to do and use ANIS. Liver function tests, CRP, and blood culture is very important also from the periphery, and also from the central line, big line or Hickman line. Most patients on chemotherapy, they receive a chemotherapy by a big line, so we have to think about this, because the treatment in this kind of patient is difficult from the patient without capacity. Have to do a PVD and looking for lactate. Yeah, next slide. Full infection screen is very important to identify and to know what we are treating. So we need to do a urine dipstick, MSU, sputum, and stool culture, and microscopy also, and X-ray test if indicated, if we think there's test sepsis, but it's not routine unless you find there's some symptom of chest problems. For the big line and central line, also we have to take a swab and ensure blood culture was taken from the lumen. There's 2 or 3 lumen sometimes, so we have to take for each lumen, we have to take a sample for the blood culture. Next, please. And also we have to take a swab for influenza, parainfluenza, and also in this situation now with the COVID pandemic, it's very important to also send a COVID swab from the nose, and also from the mouth, pharyngeal swab. And we need to be very careful about inserting a urinary catheter or doing a PR, because it can lead to transient bacteremia, and also it can introduce an infection for this kind of patient. And we need to avoid intramuscular injection because of the risk of infection itself. And this patient is immunocompromised and the platelet is quite low. So there's a risk of bleeding and risk of coagulopathy also. Next. In terms of treatment, the very important message is to treat neutropenic sepsis on suspicion only. You don't need to wait for the result of the investigation. So mainly in A&E, if you got a patient who's a cancer patient on chemotherapy on the last 6 weeks, the patient comes with a symptom of sepsis or generally unwell, hypotensive, hypothermic, confusion. In this case, I think it's very important to treat as neutropenic sepsis until proven otherwise, because we found that if the treatment is delayed, so here this can affect the prognosis very much. If the patient is treated straight away very well with fluid resuscitation with antibiotic started in less than 1 hour, so here's the outcome quite good. And this kind of patient can deteriorate very quickly. And when the patient come to A&E, there is some Intermuscular score index, which is a multinational association for supportive care in cancer. We use this score to identify whether this patient is the severity is high here or not. And there's some, we take the age, the comorbidity of the patient, and the vital sign at that time when the patient presented to A&E. And we used to stratify the patient into high risk and low risk according to the certain score. If the patient score more than or equal to 21, that means this patient is at a low risk. So in low risk patient, we can start oral antibiotic and admit the patient. But if score is low, that means this patient are high risk of complication from the sepsis, and we have to start them with appropriate IV antibiotics. As a parameter we are using, usually we take the age, the history of COPD, and systolic blood pressure at that time. And also, if this is a solid tumor or it is a hematological problem, so it is different. It's different and difficult score. We have to calculate it, and after that to decide about the plan for him. Next slide. Very important to resuscitate the patient according to ABCD approach if the hemodynamic are unstable, and to start sepsis 6 on suspicion, and you don't need to wait for the result of the investigation. And in high risk patient, we have to start GCSF, which is granulocyte stimulating factor. This is going to help boosting the neutrophil count, and we usually it depends actually the dose according to the patient weight, but you can say 300 microgram is the medium dose we can give, but it depends on the patient weight. Next, please. Yeah, this is the sepsis 6 is a 6 parameter. We have to do all of these in less than 1 hour. You have to give an oxygen to keep the SAT more than 94. Actually, this is different from patient to other. If there's a patient with a history of COPD, so the oxygen SAT here is different. And we have to take blood culture, give IV antibiotic less than 1 hour, give fluid challenge, measure lactate, and also to measure the urine output, because it's quite important for a sepsis patient to calculate the urine output, and also lactate, give a prognostic factor also. If the lactate is normal, that means this patient is not at high risk. But for example, if you find a lactate of more than 4 or 3 or 5, so this patient here is quite septic, and need to be treated aggressively. Patient should be nursed in a side room, and the protective isolation sign should be very clear and display on the door. Because why side room? Because this patient has high risk of getting an infection from other, so we keep them on the side room. And initially, the minimum for 4 hourly observation by vital sign, taking temperature, pulse, and all the vital sign, and it should be increased to hourly if the vital sign is not stable or enter the trigger zone. We have to restrict. Can you go back, please? We have to restrict fluid balance, detailing hourly cumulative balance to compare against set limit, and very important to care for the central line using aseptic non-touch technique and closed IV system. Next, please. So what is the first line treatment? I mean, here is a medication for this patient. Actually, this is quite different from trust to other. And here we have to follow our local guideline, and every doctor have to follow their own local guideline. In my hospital, we're using immunotherapy tazocine, which is TDS actually initially, but also we can escalate it to QDS if clinically indicated. And there is no role for a routine use of aminoglycoside as first line treatment unless there's specific local microbiology guideline to do so. So first line tazocine, TDS, you can create to QDS. This here in my hospital guideline. Next. For penicillin allergic patient, we give ciprofloxacin, sticobalamin, plus or minus gentamicin. Gentamicin here we give only for a patient with severe sepsis or persistent hypotension to fluid challenge of fluid, IV fluid. And the line associated infection, I said it's quite different to be treated. If you can see here, the line associated infection we treated with sticobalamin plus gentamicin. In the usual patient with neutropenic sepsis, we give tazocine. So we have to be very vigilant about if the patient got a line infection or not. So here we'll give a sticobalamin with gentamicin, and we have to consider removing the line and discuss with the microbiology. And all patients admitted with neutropenia, neutropenic sepsis need to be reviewed daily by full blood count, use and ease. Okay, next. Sometimes, in spite of giving antibiotic, the right antibiotic, as a patient is just keeping spiking. So for patients with remain pyrexia, but are clinically stable, we have to continue the same first line antibiotic. And have to take a blood culture when temperature is more than 38. And for patients who are pyrexia with a sign of hemodynamically unstable or a sign of cardiovascular instability, we have to consider additional or second line antimicrobial and treat following discussion with microbiology. Microbiology is quite important. Doctor usually contact them in case we are not certain about what kind of antibiotic we have to give. Second line antibiotic, and for patients with penicillin allergy, we usually give meropenem, which is 1 gram IV TDS. And for patients, as I said, who present with sepsis, suspected line infection, we have to give teicoplanin, gentamicin, and consider removing the line. Next. And if patient remain febrile after 96 hours, we have to consider an atypical opportunistic infection. We've seen a patient here admitted for a long time with neutropenic sepsis. So after 4 or 5 days of appropriate antibiotics, they're still spiking, and the patient is really unwell. Sometimes the cause here will be a viral infection, can be a fungal infection, or atypical organism like pneumocystic pneumonia, and we have to treat accordingly. And usually we consider empirical antifungal at this time, and we have to think also about a multi-system organism. We have to review the blood culture in the system. We have to repeat the blood culture again, and also we need to scan a patient with a CT scan or ultrasound. Sometimes maybe there's some collection in the body. So we have to think about all of this together if the patient is not responding to the initial management. When we have to stop the antibiotic, so it's quite challenging when to stop antibiotic and when to discharge the patient. Usually stop antibiotic if the patient is afebrile for more than 48 hours, and the neutrophil count is more than 0.5. And if the patient culture is positive and the patient treated with the appropriate antibiotic and remain afebrile for 48 hours. I think this is the last slide, and hopefully it will be clear and summarized. Thank you very much.